any conference, as usual, to start with, it is always a very thin attendance. And once you are going to finish again, there is a very thin attendance. So anyway, but we must stick to the time and do our job and let the people come slowly and they will join. But this is important thing, and why I understand that this topic was kept for this workshop, because this is an evolving topic as far as organ donation and organ transplant is concerned. Reason being, it has taken a real boom in Western world as far as our country is concerned. We are still struggling to how to make it successful. So that is why there are two things. What we are practicing is DBD, donation after brain death, but this is donation after circulatory death, and this is a new thing. So that is why to start with this workshop, a lecture like this, obviously convey some message to all those who are participating, and probably one or more topics on this will be discussed during the conference and people will become more aware about this. So donation after circulatory death is a method of deceased organ donation where organs are retrieved from a patient whose death is declared. Means you declared what every day we are doing so many CPCR, and we see that after CPCR we say that now the patient is dead. And criteria for death is that complete circulatory arrest, which is not reviving to whatever measures we are taking, and that is why we call circulatory arrest, and then we call it as a complete circulatory death and or arrest, and that is why we call it as a DCD. So donation after circulatory death. And it is different from donation after brain death, because what in brain death, what we do, we try to certify the brainstem function is not viable. That means we like to say that yes, now although the circulatory function is there, but as such the patient's brain is non-functional. It is a physiological death of the brain, it is not an anatomical death. So physiological death of the brain cortical function as well as brainstem function, and that is what we are currently practicing. Now, how to differentiate between this DCD and DBD? There are four major criterias on the basis of which we say that what is DCD and what is DBD. So DCD is irreversible cessation, as I said, after circulatory arrest, and DBD is irreversible cessation of the function of entire brain or brainstem as well. And declaration of death, it occurs after withhold of life support and a mandatory observation, because once the circulatory arrest has happened, after that you wait for 2 to 5 minutes, and thereafter you say that now can we go ahead for retrieval of organs, and can we go ahead with that organ donation process. And here what happens, usually we are mentally prepared and we have enough time. We have a lot of time to suggest that yes, 24, 48 hours after the brain death, because circulation is already there. So we are not in a hurry to retrieve the organs, because till the time the consenting process and all other formalities are taking place. So we have enough time. Here in circulatory death we don't have time. The time is a major restraining factor in this circulatory death, and that is not in DBD, after brain death. Now about the timing, it often occurs after the decision to withdraw life support therapies. Means you see the patient has come, you have resuscitated, you have failed to resuscitate, he has gone into circulatory arrest and take a decision to transplant. So these things are very fast. Whereas in DBD it occurs while the patient is still on mechanical ventilation with an intact circulation. So there is a big difference between the two. And then in from ethical point of view, it is very difficult to take a decision on pre-mortem consent because both these things are required here, pre-mortem consent and team separation. I'll talk about what is team separation, but in DBD, consent post-brain death declaration, because here you have much more time to say that now, yes, patient is not going to survive, you decide, so first counseling, second counseling, apnea test, so many things we do, here there is no time. Now, why we are talking about this? This is important to understand because, as I said, over the last 2 decades, there has been a significant increase in the resurgence and adoption of DCG protocols. And as I said, in developed countries like United Kingdom, Netherlands, even more than 50% of the transplant has taken up the form of DCD, rather DBD. In United States also, it is overwhelming. The patients and the families are very much enthusiastic to donate their organs as soon as they come to know that, yes, now our patient is not surviving at all, and so they are very much interested. In European countries like Belgium, Spain, Switzerland, all over it has taken over. More than 50% of the donation are undergoing after DCD. In India, there is a problem. We have only 1 or 2 centers which actually they have started. One is from Chandigarh and one another is in Gujarat. So these are the 2 centers which actually they have started. And reason being, because the kind of team formation which is required and the time of activeness and aggressiveness which is required. And the second thing is that patients' arrival in those centers where this process is being done. So if a patient who is about to die reaches a center where exactly this DCD is being done, the things become much more easier. Whereas if the patient comes to a general hospital and then you think of resuscitating him, declaring death, and then transferring to a center where it can be done, it is not possible. So that is why we have to develop this concept in most of our hospitals where currently we are practicing DBD. And we have to prepare a separate team who can actually do it in a proper way, what is expected out of this procedure. Now, poor rate of DCD in India, as I said, because of many reasons. Low deceased donation. As such, we have a very less amount of donation from most of the places we see. And if you look at the government hospitals has got a very poor donation rate, Legal ambiguity and practices, there is some change recently which has happened. Then WLST declaration, withdrawal of life support, because of lot of thought process in the back of the mind, people doesn't get ready out of this legislation. Team building, this is very, very important, as I said, because it requires a very strong team to go ahead with. And then less involvement of, as I said, government organizations, because they are the organizations where maximum this circulatory arrests happen and maximum deaths also happen. And that is why their involvement is a must. So due to these constraints, DCG is described as almost non-existent in India. As I said, only 1 or 2 places with only few isolated reports successful from one is Chandigarh, another is, and that too, what they are doing is there is a classification that is called Maastricht classification. Based on that, they have divided various categories of patient, and those 2 classes, class 4 and class 5, they have been considered for DCD, although there are 5 classes. Now, this is one article which came in 2022 in our ICCM journal, which actually gave a lot of importance to this process, that is DCD. And after this article, suddenly, and we also went through Supreme Court, a lot of petitions were filed from ICCM, ISOT, and many other organizations. And finally, what happened in Supreme Court made this legal proceedings a little bit simpler. And what they did is that they said there will be two medical teams, primary medical board and secondary medical board. Initially, this constitution of primary and secondary medical board was difficult, but now with the passage of this rule from Supreme Court, this formation of primary and secondary medical boards have become easier, and now in 2023 they have passed again a Supreme Court verdict which suggests that there are certain guidelines which makes it much easier, and we hope that in another 3-4 years process will take place in a much easier way. So the most important was the, can I have a pointer over? Judicial involvement. You see, in 2018 guideline, magistrate was required and judicial oversight was mandatory. But here, judicial role has been minimized. Internal hospital process is sufficient. And the board composition, initially they used to say more than 20 years of experience. Now they say it is only 5 years of experience which is acceptable. And then medical board formation, initially they used to say that district and state medical boards needs to be there, but now they say hospital medical board will only suffice. There is no need of involving judicial people or a state medical board or something like that. And the documentation was not uniform, but now an ISCCM and Indian Association of Palliative Care, they have made a format template and they have made it more simplified, practical and implementable in different ICUs. Now, these are the various terminologies which are associated with donation. So as I was telling, this Maastricht criteria, Maastricht classification, so there are 5 categories of patients who actually come to emergency. One is dead on a broad dead, what we say always, patients who have already come in a broad dead situation. This is an uncontrolled situation, they have described it, because this is very important to understand. And if the patient has arrived in a center where there is a facility of DCD, they can do it immediately. Second one is again unsuccessful resuscitation. The patient has come, you have tried to resuscitate but failed. Again, if those patient reaches a center where this kind of transplant is going on, it becomes easy. Okay. And then the fifth one, if you see, again, unexpected arrest in an ICU patient. This is very common, which happens in our ICU. This is again an uncontrolled situation. And again, if this happens in a center where this facility is available, you can do it. So these are the 3 main categories, 1, 2, and 5, which can only be done if the patient comes or is there in a center where this process is going on, that team building is there and that kind of facilities are there. There are 2 other categories. One is unsuccessful resuscitation. It is an emergency room at a transplant, anticipated cardiac arrest, where you see that patient may get arrested. So here, you have some time to transfer the patient to a nearby transplant center. And the cardiac arrest in a brain dead donor, this is what we are following. Currently in India, this is the category, cardiac arrest in a brain dead donor. And 5 is unexpected arrest in ICU. And that is why the Chandigarh people have been able to do 1 or 2 cases of DCD, and Gujarat people have been able to do 1 or 2 cases of DCD. The 4 and 5 criteria, these controlled and uncontrolled situation, these are the cases they have attempted and they have become successful. Now, what are the procedure and protocols? So, as far as controlled DCD is concerned, that is Maastricht class 3, as I said, expected circulatory death in ICU, where you see that, we can transfer the patient to other. In all patients where all curative treatment options have been exhausted and ongoing treatment is considered futile, the process of WLST and end-of-life care may be initiated. Here, the process goes like this. First is withdrawal of life support, patient goes into asystole, then you have to see that now your patient has arrested, he is no more. So 5 minutes you have to wait for that. So that again, if the spontaneous circulation reverses, then there is a problem. So you have to make it sure that it is not reverting. Then you declare that death and then organ preservation. So this time is warm ischemic time. This is very, very important. And that is what actually it needs expertise and the involvement of critical care persons a lot. Once you declare, till the time of declaration, everything is fine. But after that, wait for 5 minutes so that it does not get reversed. And in the meantime, you have to see that organs are at least transplantable. So that is why this is very, very important. The second is pathway for uncontrolled DCD, that is class 1, 2, and 4, where I said the situation is absolutely broad dead patient. Suddenly it has happened in ICU. And those patients, here you have to do a CPCR of 30 minutes. And then again after CPCR you have to wait for 5 minutes so that dead determination is done. And then this warm ischemic, this, you see the long warm ischemic time over here. And these are the most difficult cases where you can see yes, whether. Second thing is that the critical care physician has also to understand that yes, okay, the organ has been retrieved, whether it is going to work on the other patient or not, that is very, very important. So very close monitoring and time is very, very important. So that is why this is. And the third one is the class 4, which is the most tricky one. Cardiac arrest happens in a brain dead donor. So already a brain dead patient is there and cardiac arrest has happened. Now what you have to do? In eligible donor who have been certified after both sets of tests, you know that we do 2 sets of apnea tests and then we declare. So CPR and the no touch period are not required here. Okay? Here things are a little bit different. Donation can be performed. But in a potential donor, where, because here consent, everything, all these formalities are already clear. Now, in those cases where only one set of criteria has been satisfied, here the only test that has been confirmed, CPR has to be performed for 30 minutes. So, because you have performed only one test, patient has suddenly gone into arrest, you have to do CPCR for 30 minutes. And the third one is, if DN, do not attempt resuscitation, has been signed, CPR is not required. And, but again, as I said, 5 minutes of no touch period has to be there, and you have to see that patient is silent, your ECG is there, your all monitoring systems are in line, and that suggests 5 minutes has elapsed. No, there is no activity, now you can go ahead. Okay? Now, what are the important things for critical care physician? Time is very, very important, and because I just now explained why time is important, all those diagrams which I said shown that suggest that how much time is important. Then second is end of life priority. It is our job as a critical care physician to be very compassionate with the patient and family member. And you have to explain them. The end of life care will continue. If you see that you have tried attempted resuscitation, you know that the patient is going to die, here you have to be very compassionate and you have to explain the patient's family member that this is going to happen, and before transferring also you have to counsel. So all those things are very, very important. Next is prognostication and time to asystole. So DCD is most feasible in patients. He is expected to die within a relatively short period of time, within 60 to 90 minutes, anticipated. You know that in another 1 hour or 1.5 hour, patient is not going to survive. You have got that feeling. Here, intensivists in collaboration with the organ donation team needs to assess the likelihood of death within this window to ensure organ remain viable for transplantation or not. So, as soon as you come to know that yes, the patient has got a very limited time period of survival, you need to activate everyone. And you need to have a very good coordination with the organ retrieval team and also your NGOs who are working with you so that patient party is taken care of. And then immediately you also have to discuss and inform to the ROTO and SOTO team, whichever is available in your place. You have to tell them, or organ procurement organization. So again, this communication with different stakeholders is the job of intensivist. It is the job of intensivist. You have to say, inform it to SOTO people, inform it to organ procurement, inform it to NGOs, everybody. So make it the intensivist responsibility to ensure the patient's medical management, and in the meantime, you have to see that organs are preserved also. So both administrative, compassionate job, you are doing administrative job, you are doing that compassionate job with the patient's family member, and in the meantime, you are taking care that organs are preserved. It is not dying before transplantation. So you see, you have got a tripartite, such an important job if you are taking care of these patients. So that is why very important. Then withdrawal of life support decision always stays with intensivists. We always discuss. So this decision is very, very crucial, as we know with BD, DBD. So it becomes more important for patients with DCD. Okay. And protocol implementation, as I said, after you resuscitate, see that patient has not survived after resuscitation, that 2 to 5 minutes time. Because if you go beyond 5 minutes, then the organ reperfusion is not going to give rise to good outcome. Very important to remember. Then post declaration organ preservation, as I said, this is very important. And then comes the ethical and policy consideration. Dead donor rule. Organ recovery for DCD can only occur after the irreversible cessation of circulatory and respiratory function, because this is what is DCD, and this means the patient must be declared dead before any organ retrieval procedure begins. So, dead donor rule, you have to declare dead, then only patient can donate. Or the body will donate, or you can take organs from the. So a hands-off period of 2 to 5 minutes, that is very, very important. Then separation of care and donation team. Now, here the patient party may think that suppose the organ retrieval team comes and they try to convince the patient's family member. Then the family member may think, oh, the patient party has, this doctor has got vested interest in doing transplantation. So, there has to be a norm which you have to maintain, that yes, two parties are talking in a different way. The medical team is responsible for patient's care and the decision to withdraw life support and should be distinct from organ procurement team. So both parties have to behave separately, that the patient family member should not think that, oh, the hospital is trying to do it for earning money. This is very, very important, and this thing again is the job of intensivist. You have to say that, no, I have seen, I have evaluated, I have identified, investigated that this patient is not going to survive. So now, this is high time to take a decision. Getting my point? So that is called decoupling both the teams, okay? And then informed consent, where and how life support will be withdrawn. The time interval necessary to observe for lack of circulation before declaring death. And then another thing that is very important, which I have not described, is the possibility of a stand down where the patient does not die. Suppose you thought the patient is going to die within 90 minutes or 2 hours, but you say, oh, he is not dying, he is still continuing. It is not in our hand, no? You cannot force the patient to die, or you cannot create a situation where you can kill the patient. So this is a very important possibility of a stand down. This is called stand down, where the patient does not die within the prescribed time window, in which case the donation does not proceed. So that part also you have to take care, and end of life care continues. So both the sides, these are very tricky, and the use of antemortem intervention, as I said, to preserve organ viability, again you have to. And clinical challenges, warm ischemia time, as I said, because this is very important, that 5 minutes which you are allowing, that okay, there is no activity for the patient, and immediately you have to insert cannulas and other thing to reperfuse the organs. So that is again a very tricky situation. To have to do things very fast. So organ preservation strategies and NRP, because after that normal regional reperfusion has to be initiated. And these are very useful for abdominal viscera. On the one hand, you infuse blood or you start initiate circulation. On the other hand, you have to see that the circulation is not entering the brain, because again, otherwise suddenly if the patient gets up, then the things will become very difficult. So to conclude, the 5 most important perspective of critical care in DCD is optimal end of life, compassionate care, as I said, coordination with WLST, withdrawal of life support team, treatment as well as team for, then declaration of death to adherence hands-off period, that I said, 5 minutes, maintaining, in the meantime you have to maintain the organ viability, that is called pre-mortem interventions, and then ethical and legal adherence and communication, as I said, amongst all those who are the main stakeholders for this kind of transplantation. Thank you very much.